Welcome to the eJournal Club on another very interesting article that I reviewed today. So, I wanted to share my impression from the article. My name is Danish Bhatti. I'm a movement disorder neurologist, and my primary interest is in Parkinsonism or Parkinson's disease, where I do most of my research. So, I wanted to review this article, which you remember, like other articles I've shared, this review is not a replacement for reading the whole article. The articles may not always be available in public domain, so I will not try to share the article with you. However, I will let you know if it's available in the public domain so you can look it up. And I will add my impressions and comments or other background or contextual information into the review so that it makes more sense to you. So it serves a purpose for teaching. Very good. So with that background, let me start with this article. This is Advances in Progressive Supranuclear Palsy, New Diagnostic Criteria, Biomarkers, and Therapeutic Approach. It's a very comprehensive overview of the updates or new concept in progressive supranuclear palsy. I will try to make it so that you at least understand what PSP is, even if you're not familiar with this disease. But some basic familiarity would help understand this review much better. So the article is actually published in the Lancet Neurology in 2017. If you go to the Lancet Neurology journal directly, the article is not publicly available over there. It seems like you need to purchase it. But if you search it in PubMed, it shows up that there is a link of a link where the article actually is how do you say it is in PMC or PubMed Central. So any article that is published which uses funding from government to do the research or any component of the research or supports any of the writers, then the article has to be in public domain, freely available. So there is a PMC Central link available. So if you go on to PubMed and search the article, you can actually go and get the full article available. So with that, let me quickly jump into the article. I am familiar with a couple of the authors here. Tony Lang is here, and Irene Litwin is here. So I am familiar with their work before and have good respect for them. But it looks like it has a comprehensive combination of experts, including Dr. Tai Yu from Qingdao in China. So the article is talking about progressive supranuclear palsy and is highlighting some information about the pathology such as the 4-repeat tau, new diagnostic biomarkers that have become available or being studied, tau-directed therapies. Although the article is not geared toward it, so it introduces the concept but doesn't comprehensively summarizes it. So it basically just touches on them, and I actually want to touch on it even less because the strength of the article is the understanding of the clinical PSP itself. Um, One of the important concepts to understand before I go into the article is that the article distinguishes between the disease diagnosis and the clinical diagnosis. So the clinical diagnosis is a clinical suspicion, which now is considered either possible, probable, or suggestive, but is never definitive because of lack of any clear diagnostic test. So the only definitive diagnosis is the tissue diagnosis. When somebody passes away, you do autopsy, you look at the brain, and then you can know for sure which is the pathological diagnosis or definitive diagnosis. So a lot of time when we are saying diagnosis, you have to be careful between which diagnosis we're talking about. A clinical diagnosis, which is kind of a probable or possible diagnosis, or the true diagnosis or definitive diagnosis, which is the tissue diagnosis. Um, Very good. So the progressive supranuclear palsy, originally described as Richardson syndrome in 1964 by Steele, Richardson, and Olszewski. Um, and initial thought was the prevalence is pretty low, 5 to 7 cases per 100,000. But now PSP pathology in the brain has been linked with many different clinical presentation, not just the classic Richardson syndrome, and that's what this paper will highlight. And based on the autopsy, where you can actually confirm a definitive tissue diagnosis of PSP, the prevalence is probably much higher. It actually quotes some data later on that we will look at. It also gives referrals to the MDS criteria for diagnosis of PSP that divides it into suggestive, possible, and probable in different subtypes. This article does not summarizes or reviews the MDS criteria for PSP. So that's a separate paper. It's worth reading. It's a very good landmark paper for the diagnostic criteria, but it makes good referrals to it in where MDS is talking about PSP in what sense, as it is focusing only on the updates of the new concepts. So, suggestive of PSP is basically any individual who has developed a mild or isolated symptoms that are concerning for PSP, but may not be PSP, and maybe something like Alzheimer's or a kinetic rigid form of Parkinson's disease or frontotemporal dementia or something else that have things that make you worry about PSP, but not enough to make a definitive diagnosis. I'll explain a little bit more in terms of Richardson syndrome, where it's more easy and clear to understand when it is clear to make a diagnosis, when it is not clear to make a diagnosis. But there are many other clinical presentations of PSP, which we call phenotypes of the PSP pathology in the brain, where it is more difficult. So that's where you really need to know the diagnostic criteria very well or have it available in front of you or look it up. But anyone who is not fulfilling the criteria enough to be considered possible PSP, one of the phenotype, is suggestive PSP. Now, suggestive PSP is a little more difficult um, uh, condition, and we will come back to it. So the article then talks about uh, that besides the Richardson syndrome type of PSP, the other variants of PSP are so hard to diagnose that most of the time, the only time you know for sure or conclusively is after the death. Um, so it gives some example. For example, um, two-thirds of the patients with neuropathological defined PSP, the initial presentation, the first 2 years, looking back in the chart, was not consistent with PSP at all. And later on, they developed the more classic PSP. So even when patient is presenting with PSP Richardson syndrome or PSP-RS, it may still not be clear in the first 2 years of the presentation and may become more clear later on. Um, but there is definitely a presentation of PSP, which is called PSP Parkinsonism or PSPP, where patient is clearly presenting with classic Parkinson's. And then it lists the other types. So there is the PSP with progressive gait freezing, PGF, or sometimes called pure akinesia with gait freezing. There is also PSP with CBS or corticobasal syndrome presentation. Um, I'm just listing them now, but the paper will actually go through them. And there is the primary progressive apraxia of speech or non-fluent progressive aphasia. So the primary progressive aphasia, fluent and non-fluent type. The non-fluent type can be a presentation of PSP, and that is now called PSP with predominant speech or language disorder. So PSP-RS, PSP-P, PSP-PGF, gait problem, PSP-CBS, and PSP-SL or speech or language problem. And the last one that is commonly seen is the PSP-F or frontal presentation, which is basically a frontotemporal dementia variant or behavioral variant of frontotemporal dementia. Now, uh, remember that frontotemporal dementia can present with a non-progressive aphasia, primary progressive aphasia, and that's the non-fluent variant, which is PSPSL. And now the behavioral variant of FTD can be a presentation of PSP, which is PSPF. Now they can also be presentation of frontotemporal dementia themselves, which basically is more common. But a frontotemporal dementia-like presentation, either as behavioral variant or primary non-fluent primary progressive aphasia, can actually be a PSP pathology in the brain, and that's where they're called PSP, PSP SL and PSPF. And then finally, I first read about this here in this paper. Let me say, I probably have read about this before, uh, but I just didn't remember if I did before that there is this PSP with predominant cerebellar ataxia or PSPC. Now, this is an extremely rare representation, as it will show later on from some of the autopsy data. Extremely rare. So, and it is just undiagnosable. But it said something here that made me wonder, and I'll come back to it. Very good. So, then it talks about this concept of pre-symptomatic PSP phase. This concept is very similar to concept of Parkinson's disease. Now we have the preclinical Parkinson's, and then pre-diagnostic stage of Parkinson's, so pre-symptomatic, and then which is preclinical, and then pre-diagnosis, and then the diagnostic phase of Parkinson's disease. So all of these neurodegenerative disorders are starting so slowly that for a while they don't even develop symptoms. So this data actually comes from looking at autopsies of people who didn't have any PSP symptoms, and it was showing that as high as 4.6%. So this data is from Japan, and it's basically showing that 626 individuals older than 60 who had a forensic autopsy series in Japan, 4.6% of them have PSP pathology in their brain, and they never had symptoms of PSP. So then it goes on to the suggestive state of PSP, which is the pre-diagnostic stage kind of Parkinson's disease, and then it shows you this map that patient may be asymptomatic. This is the figure one of progression. So pre-symptomatic PSP, and it may never progress, and the patient may die before they have any symptoms, or they may never have symptoms, and then you only see it on random autopsies. But it may go on to develop some symptoms, not enough to be diagnostic, and then that's the suggestive state of PSP, and then the patient can have a death during that state and never progress any further. Or it may go on to progress, either develop Richardson syndrome or develop a variant presentation of PSP. And then it shows, interestingly, that many variant form of PSP can actually go on to develop that Richardson syndrome, kind of a classic PSP presentation that we will look at in a minute. Now, this figure 2 is very interesting, and it is discussed later in the article, but I wanted to just get this out there that the clinical diagnosis or clinical phenotype may be completely due to another pathology. That's one of the challenge for being a clinician, is that you're looking at a patient, you're making a diagnosis, and you're saying diagnosis like MSA, multiple system atrophy, progressive supranuclear palsy, corticobasal syndrome, corticobasal syndrome, Parkinson's disease. But these diagnoses is just this is just a label onto the clinical constellation of symptoms and signs that the patient have. It has some correlation with what's going on in the brain, but it often breaks. So something like Parkinson's disease, it may probably doesn't break that often, but in other conditions, in the more rare syndromes like corticobasal syndrome or PSP or some variants of PSP, it may break even more often. So the clinical presentation of a patient can be reached from many different changes in the brain or pathology in the brain. Similarly, same pathology in the brain may present with many different clinical pictures. So it's kind of a very mishmash of things going on, of various types of pathology and various types of clinical presentation. And we are starting to clarify these with these kind of review papers like this one. But what we're trying to stress is that for drug development, for research, for biomarkers, we have to start talking more in terms of the pathology in the brain, even though it may not be applicable on the next patient you see because you don't have pathology on that patient. All you have is clinical phenotype. So our clinical practice forces us to use the clinical syndromic diagnosis, a clinical phenotype diagnosis, and just try to treat them based on that. But if you're doing a drug development, you need to be aware of what that actual pathology in the brain is. And some of these diagnostic criteria, such as the MDS criteria for PSP, make an effort to try to correlate the two so that there could be better drug development. So, to give you an example here, what this paper has done is develop this nice graph, which basically is saying that if you take 100 people with a clinical presentation, and let's say Richardson syndrome right on the top here, and out of those 100 people, let's say 90 or 95 of them will have the PSP pathology as shown by being on the left side of the line, and 5 or 10% will actually have another pathology, even though they look like PSP, Richardson syndrome, fulfilled all the criteria. And that's a small portion there. And then there is an overlap zone where they had both PSP and other pathology. Other pathology could be Alzheimer's disease pathology, could be Parkinson's disease pathology, trauma, and so on and so forth. But this becomes murkier as we go to other subtypes. So, for example, PSP Parkinsonism, significant portion, maybe 60% of them actually has Parkinson's pathology and only 40%, roughly speaking. These are not accurate numbers. I'm just trying to depict you the gravity as explained in these graph. of how they look, and it go down and down, and the portion of the clinical presentation being caused by the PSP pathology in those 100 people becomes smaller and smaller. Some of these diseases, for example, PSP frontal, which is a behavioral frontotemporal dementia, the PSP pathology is seen in very few people. So what it means is that when someone is presenting with a type that may be a PSP phenotype versus, so, or let me say it this way, somebody presents who looks like a behavioral variant frontotemporal dementia is likely behavioral variant frontotemporal dementia, and there is a small chance that he has a PSP frontal, or he has PSP pathology in the brain, although he looks like behavioral variant frontotemporal dementia. Now, does it matter? Should you call him, um, should you call him PSP? Should you call him frontotemporal dementia? That sometimes becomes challenging, especially if the patients are very concerned about their diagnosis, if they want to read on it, if they want to be accurate on it. That becomes difficult, and it becomes even further difficult if everything fits, but you see this one or two features that reminds you of PSP. So for example, a behavioral variant frontotemporal dementia patient also having eye movement problem. Now you're stuck. It's like, okay, is this PSP presenting as behavioral variant FTD, or is behavioral variant FTD mainly? And this sign that I saw is not very reliable, and that's the problem, that the reliability of those symptoms and signs that you may see in other settings is just not well established. It's not very well known. Similarly, PSP Parkinsonism. So it's a patient who ends up having PSP pathology in the brain, but looks like Parkinson's early on. Although there are some things that are just odd about the patient. Patient is not very asymmetric, or have gait predominant involvement. Then you're worried about PSP, but you're not sure. It may fulfill a suggestive PSP criteria, but not PSP Richardson. But there's a good chance the patient actually has Parkinson's pathology in the brain. He just looks odd, but it is Parkinson's, and that's kind of the challenge here. So, anyways, coming back to the paper here, I'm gonna quickly go through the different subtypes and highlight some of those things. So, PSP Richardson is probably the easiest one to diagnose. That's the one that classically has the vertical supranuclear gaze palsy, where there's difficulty in lifting the eyes up, even though the extraocular muscle strengths are normal. So, it's the conjugate vertical control of the eyes, which is the supranuclear control of the eyes. Nuclear mean the nucleus of the cranial nerves that control the muscles, so cranial nerve 3, 4, 6. So above the nucleus of those cranial nerves is the supranuclear, the frontal brain problem, which is not lifting the eyeball up. But this may be a late presentation, and earlier signs may be just a decreased velocity or slow movement of the eyes upwards, and lower amplitude. If you do a saccade upward, then the amplitude is actually small. It does only small jerk upward. um, and one of the most sensitive way might be to look at the what we call optokinetic nystagmus, which is repeated saccades on trying to follow something. You could look it up online. There's probably good videos on what an optokinetic nystagmus is if you're not familiar with it. The other type is PSP Parkinsonism, which becomes now less and less clear and more difficult to diagnose. This is someone who just presents like Parkinson's disease, but has something odd about him. He may have a very symmetric disease. He may have a partial response to medication. He may have early falls and balance problems, subcognitive impairment. So some things that remind you of PSP, but otherwise he looks more like Parkinson is responding to medication, and there is moderate response to levodopa. Now remember, there is an akinetic rigid form of Parkinson's disease where pathology is PD, and that looks like PSP. Some of these things I mentioned, like cognitive impairment, symmetric disease, moderate response to medication. So, and remember that figure 2 that I showed earlier, that out of those 100 people who are like these, majority of them, 60% or more, probably are still Parkinson's disease pathology in the brain, and less than 40% are probably this PSP Parkinsonism. But again, these are made up number. I don't have actual data based on autopsies here. PSP with progressive gait freezing is even more difficult to diagnose unless patient is presenting with a pure gait freezing early on. So an isolated gait disorder with early start hesitation and subsequent freezing of gait has a strong association with PSP, very strong association. So these patients doesn't have much of a rigidity or bradykinesia, and they just have a strong gait freezing as their initial presentation. I've seen maybe 2 of these patients out of the 3,000 patients I've seen over the last 5 years with Parkinsonism. Another one is the PSP corticobasal syndrome. The CBS is classically characterized by a strong unilateral apraxia, alien limb, sensory loss, or unilateral dystonia, Now, Parkinson's disease, especially young onset, can have a hemidystonia and very strong, but it's the apraxia with or without cognitive impairment and some cortical features is classic for corticobasal syndrome, and it can be the presentation of PSP. Now, corticobasal syndrome is another tau abnormality that we will come to in a minute, and that's why it kind of can look like the same. And then I mentioned the non-fluent primary progressive aphasia as a presentation, which is usually a presentation of frontotemporal dementia, but the pathology in the brain can be PSP and is now called PSPSL. And similarly, there is the behavioral variant of frontotemporal dementia presentation might be due to PSP pathology, and that is the PSPF, where there is apathy, rigidity, disinhibition, and hyperorality. And then the last rare presentation that I mentioned earlier is the PSP with predominant cerebellar ataxia. Now that's something that has just dropped my mind. After reading it today, it looks like as if I heard about it for the first time. I'm sure I heard about it before, um, by just it just it slipped my mind. And it's interesting that out of 100 and 1085 PSP pathology confirmed patients, only 5 fulfilled clinically the primary cerebellar ataxia presentation, and 4 of these 5 were diagnosed as multiple system atrophy, type C, cerebellar type of multiple system atrophy, and that's what I would probably diagnose someone as who's presenting with a primary cerebellar ataxia. Now, the interesting thing, that thing here that touched me in this paper was that they said these MSA diagnosed patients, the 4 patients MSA diagnosis, actually had normal autonomic testing, no dysautonomia. Now, that's something I have used for diagnosis of MSA based on the current data on MSA. 97% of patients with MSA have dysautonomia. Now, those 3% that don't have dysautonomia in the studies, which were clinical studies, clinical diagnosis of MSA not by experts, super experts, but not autopsy proven study. So the question is that how many autopsy proven MSA don't have dysautonomia? And the answer might be zero. I actually will have to now go and search the literature for this question because it's going to bug me. Because I have used this autonomy, dysautonomy as a diagnosis of MSA, a patient presenting with early Parkinson's, many atypical feature, gait problem, ataxia, or primary ataxia as presentation, slowly progressive late age. I'm looking for MSA diagnosis. And one of the clues I use beside that scan that I occasionally do is to look for dysautonomia, because 97% of patients have dysautonomia. And if you do autonomic function testing, which we're lucky to have at University of Nebraska Medical Center, very easy to do in our center, and that's if that's present, I make the diagnosis. Now, there are patients who I think clinically look very much like MSA. Well, probably. Now I'm gonna think about it a little bit because I've not paid attention to their eyes. I've not, and they have early balance problem in fall, but they look very cerebellar ataxic and Parkinsonian, not very medication responsive, but they don't have dysautonomia. And these patients, the PSPC patients, the 4 out of 5 patients with MSA diagnosis, actually had a normal autonomic testing. Now it's gonna keep bothering me that all those patients PSPC that I have seen, those few patients, say maybe 2 or 3, um, or is it something else going on? And then finally, of course, there is this category of what we call PSP with mixed pathology, with a lot of things going on. As I showed also in figure 2, there was kind of a border between the two. Now, in terms of updates to PSP, there are very interesting findings here. I have this beautiful figure in this paper that I wanted to show you to make things clear. Now, PSP is due to this most of the genetic form of PSP, or even a lot of non-genetic form of PSP, is due to what is this called the MAPT locus. MAPT is the microtubule associated protein tau. That tau protein is basically the pathology of PSP. So this MAPT protein, if you look at this picture here, is on chromosome 17, is 17q21, and that it's a long protein, it has multiple exons, and these are numbered here: 1, 2 is in red, 3 is in blue, and then there is 7 numbered here, and 10. 10 seems to be the main area of all the mutations listed in this box here that lead to genetic forms of PSP. Now, MAPT actually occurs as 2 different haplotypes: H1, direct orientation, and inversion, H2, which is 75% and 25%. Now, a double H1 haplotype is considered a very high risk of progressive supranuclear palsy, even without any mutation. 5.5 times odds ratio. And H1 is the most common form of haplotype of MAPT. Now, interestingly, this protein, tau protein, when it is created with these 10 exons, can have 6 different forms. These forms include one that has all 10 exons, as listed here, or it could be that exon number 3, the blue, is missing, or exon 2 and 3, red and blue, are both missing, or the exons 2 and 3 are present, but exon R2 or exon 10 is missing, or the exon 3 and 10 is missing, and both 2, 3, and 10 are missing. So based on these combination of 3 exons, 2, 3, and 10, there are 6 different variations that are possible of an tau protein. So when I say exon is missing, it's not that it's missing on the gene. What I mean is that the exon is not translated into the protein. So protein can be spliced from the RNA ribosome conversion into these 6 forms. Now, these 4 regions, R1, 2, 3, 4, which is around 10, which forms the R2, is basically what is describing the 2 types of tau, which is the 4T tau or the 3T tau. The 4 tau is the one that has all these 4 domains, R1, R2, R3, R4, so meaning that they have the 10 number in there. And 4 repeat tau, repeat 1, repeat 2, repeat 3, repeat 4, is basically the tau associated with um, PSP, with Alzheimer's disease, with Down syndrome, with chronic traumatic encephalopathy. Now, the 3 repeat tau, where 1 repeat of the exon 10 is missing, it also exists in brain and has been mostly linked with the Pick's disease and myotonic dystrophy, but not with PSP. Now, and these Ys, if you're wondering, are basically antibodies that you use to mark all these tau to measure. And as you can see, that they are not influenced by the repeat number, so they will measure the total tau regardless of our repeat 3 versus repeat 4 status, 4 repeat versus 3 repeat status. But the 4 repeat tau is the one that we're worried about in Alzheimer's and in PSP, and it's the accumulation of abnormal 4 repeat tau as clumps, tangles inside the neurons, outside the neurons, that leads to the pathology of PSP. So that's kind of what we have now very well understood on how this pathology or genetics contribute into the formation of PSP, and that's why that we now have targets on where to treat to try to get rid of those tangles of proteins in the brain. One interesting thing was this MRI-based finding that atrophy of the midbrain and superior cerebellar peduncle is a useful marker for PSP Richardson subtype, but not useful for other subtypes of Parkinson of PSP. It has huge, 100% specificity. You can see it as either a hummingbird sign in axial slices or a morning glory sign in sagittal slices, but they are not very sensitive, 68% for hummingbird and 50% for morning glory sign. However, if you do what is called an MRPI, magnetic resonance Parkinsonism index, which is basically a ratio of the volume of pons and midbrain, then you can reach a sensitivity of 100% and specificity of 99 to 100%. So extremely useful tool, but I am not sure if it is replicable, and it's not definitely available. Volume-based assessments not available in my center, so I have not used it in our center. It basically mentions there is a different ligands that can bind to the tau that are being looked at, but currently their role is not very well established. They cannot be used for diagnosis, they cannot be used for progression, but the science is evolving, so we will soon have these dye tracers that you can inject to the patient and get tau burden in the brain. The most interesting finding is the CSF and blood biomarker. So what basically is showing up is that for clinical diagnosis of PSP, they're looking at a 2 to 5 time increase in this neurofilament light chain, NFLC light chain, neurofilament light chain concentrations. And now it was initially seen in CSF, and now it can be seen in blood, and it's now starting to become reliable. The problem with this use is that it is not compared with the autopsy. So that MRI findings were basically compared with autopsy diagnosis, not clinical diagnosis of sensitivity and specificity. But these CSF and blood markers are not yet, but soon they might be, and then you may have a blood test available, as this neurofilament light chain is measurable in blood on current testing kit. Now, the paper actually go through a long list of these studies that are looking at biomarkers and insight, and I'm not going to review them. If you are interested in that much detail, you'll have to get the paper, and as I said, it's available for free through PubMed and PMC Central. Therapeutic approaches, again, I will just give you a glimpse of it, and something I'm not going to focus on the review today. Coenzyme Q10 has shown some promise. Deep brain stimulation failed, and we're studying a lot of drugs which work on these microtubule proteins, or tau, microtubule assisting protein, or tau, which are being studied in PSP. I highlighted these studies here, which are looking at different components in this picture. Beautifully summarizes various targets that can either reduce the gene expression of that E10, that abnormal exon 10, that repeat 2, that needs to be removed to convert 4T to 4 repeat to 3 repeat tau, and that will reduce the 4 repeat burden. Or it can be a modulation of the post translation. So once translation happens, this is a microtubule here, and then a tau is basically coming to help it out. But if it's abnormal, there are various ways to clear it out. And then lastly, once a cell dies, that tau is released out into the intracellular matrix and forms tangles there, and can be taken up by other cells, and that where you could block it so that the progression slows down and there is a slower spread. But again, you can look up the paper for details on these. I will not review them this detail. So this was kind of my take on this paper. It was a very nicely done paper that I really enjoyed, and I learned new things. I organized the PSP subtypes in my mind based on this, understood the pathology, current understanding of it, and the genetics update and the therapeutics update, and hopefully you found it useful too. And up until then, we'll see each other in the next journal club. Thank you so much.